Do I start? So why don't you come closer so that we don't have mic? Come closer. Because this is not the lecture we used to have, full classes. It's only 15, 20. And if I take attendance, there will be 100. Hmm? Okay. Dosing adjustment in renal dysfunction or renal failure or renal compromise status, whatever you call it. In this lecture, we'll discuss the effects of renal dysfunction on the pharmacokinetic parameters of the drugs. Basically, this is the clinical application of what we have already learned in POD block. I will repeat some of the same graphs which we used to have in POD. And when you have to use a drug in a patient with renal dysfunction, what are the approaches you need to employ for the safe administration of the drugs, and the commonly used formulae for the estimation of glomerular filtration rate, GFR. Now, you know the kidney is an important organ in regulating body fluids, electrolyte balance, the removal of metabolic waste, and also drugs from the body. So obviously, with these functions in your mind, any dysfunction of the kidney will have a huge impact on the handling of the drugs, on the metabolites and electrolytes, water balance. So you had this is very important science, a separate science, how the pharmacokinetic changes in renal dysfunction and how to mold your strategies according to the situation. We'll discuss. Basically, these are the broader concepts. Nowadays, computers, AI assisted calculations, you are not supposed to learn by your heart. Broader principles, what do we do generally? We learn renal impairment. Now, look at this bullet. Renal impairment modifies the effects of many medications. Occasionally, it diminishes the effects of drugs, renal dysfunction. But in most of the situations, the effect of the drugs is enhanced. The effect of the drugs is enhanced is obviously understandable because there's a decrease in the excretion or elimination of the drug from the body. The drug will accumulate over time. Am I right? So, in that case, the effect of the drug will be enhanced. Can you think of some drugs where renal function dysfunction actually decreases the effectiveness of the drug? Hmm? You know. Hmm? Question is, renal impairment modifies the effects of many medications, either increasing or decreasing, occasionally diminishing them, but more usually enhancing or even multiplying them. Generally, we know because if the drug is not eliminated, it will accumulate and the effect will increase. But can you think of the situation where renal dysfunction decreases the function of the drug? Mannitol, almost all the diuretics, loop diuretics, hmm? Vitamin D, yes, vitamin D, because it's the activated form 124, 25 calcitriol is activated in kidneys. It's a renal dysfunction. Activated form of vitamin D will not be synthesized. Yesterday, Manal must have told you diuretics, especially three diuretics, loop diuretics, thiazides, and mannitol, as you mentioned, they must be filtered or they should be secreted, especially the furosemide and thiazide diuretics. They must be secreted. And secretion is a function of kidneys. If they are not secreted because they act from the tubular side, from the luminal side of the tubules, from the luminal side of the tubules. If they are not secreted, they are not in the tubular fluid, their action will be decreased, diminished. So kidney function is required for the optimum action of furosemide and other thiazide diuretics and vitamin D also. But these are minor, not many drugs. Majority of the drugs, their action increases. Yes.
What the drugs that are broken down by the liver, so this function will be processed again more frequently.
Because there, in that case, now the liver has nothing to do with kidney. We are talking about kidney function. The function of kidneys mainly is to eliminate the drug from the body. Clear? So in that case, if the drug is not being eliminated from the kidney, the drug will accumulate. If it accumulates in the body, sooner it will reach a level which is toxic. I will explain in the next slide. So in most of the situations, the toxicity is enhanced by the renal failure, but for some of the drugs, efficacy becomes decreased, as in the case of diuretics. Okay? Many of these alterations can be and should be predicted and alleviated by adjusting drug doses. Okay? Many pharmacokinetic parameters like absorption, bioavailability, protein binding, volume of distribution, metabolism, and excretion all may be affected, but mainly it is the excretion, metabolism or excretion which is affected. If in certain situations of CKD, the extracellular volume is expands. In that case, think about the consequences. When your extracellular fluid compartment is expanded, what will it affect on the fate of the drug, pharmacokinetic profile? Volume of distribution will increase. If the volume of distribution of the drug is increased, that means what will be the effect on the half-life of the drug? Increase. Half-life of the becomes longer, the duration of action of the drug will be increased. So all these are interrelated things. Okay. So in that case, pharmacokinetic parameters will be altered in case of renal dysfunction. Let's discuss one by one. Now, see, relationship with routes of excretion. So let's plot a curve. On the y-axis, we have clearance of the drug, and on the axis is GFR. Now, interpret this type of curve. As the GFR increases, so the clearance increases. The interpretation is the drug is being cleared or eliminated mainly through kidneys. Because GFR increases, clearance of the drug is increased. So, kidneys. Now, look at this curve. What does this mean? Hmm?
There is a certain amount of no matter what the level of the
So, so that means what is the interpretation about the route of excretion?
that would be a
Not renally excreted. So we don't know about the other route of excretion, but it is the clearance of the drug is not dependent upon GFR. You are going to increase the GFR, no effect on clearance. That means the drug is not cleared by the kidneys. We don't know about other route. Okay. What about this one? More than one route. So as the GFR increases, definitely the clearance is increasing. But compared to this one, it is not to the extent. That means we can easily interpret that this drug is partially excreted by kidney and partially by some other route. Exclusively non-renal route, exclusively kidneys and partially other route. Are you with me? Now, this is the typical example, gentamicin aminoglycoside, exclusively through kidneys, doxycycline excreted through bile, and it undergoes enterohepatic circulation. That is why the half-life is long. Okay, and cloxacillin, that is penicillin, it's excreted through both bile as well as through kidney. Okay. Now this is a graph which I shared with you in the POT block here. Now the steady state concentration, CSS, is the concentration of the drug, steady state, where at certain point the rate of inflow of the drug through multiple dosing into the body becomes almost equal to the rate of excretion. So the drug is coming and the drug is leaving. There's a, you see, a steady state is maintained. Now, in order to achieve a steady state, how many half-lives are required? Do you remember? 5 to 6, 5.5, something like that. Okay. These half-lives are required to achieve the drug into a steady state. I had mentioned this. Okay. One dose, half-life, provided the drug follows a first-order kinetics of elimination. Do you remember? First order and zero order. A constant fraction of the drug is being eliminated per unit of time. Second dose, second half-life, third dose. So about 5 to 6, between 5.3 half-lives are required to achieve a steady state. Now think of a situation, this is normal. In renal dysfunction, as I mentioned, it would be like the drug will accumulate. If the drug is accumulating, how? Suppose the drug is being eliminated slowly because there is a kidney dysfunction. The main function of kidney is to eliminate, excrete. Now that function of the kidney is compromised. The drug eliminated will be slowly, less than normal. Suppose in that situation, the curve will become like this. Am I right? Slow. And then you administer another dose, and then another half-life, once again slow. Third dose, soon. After 2-3 doses, the drug accumulates to such an extent that it may become toxic. Am I right? So in that case, you have to do certain things. The first thing is estimate the extent of kidney dysfunction. Estimate the extent of kidney dysfunction, and the best measure to do this, because you cannot measure directly kidney. There's no mechanism, kidney ultrasound or CT. What is the serum creatinine? The most commonly used is serum creatinine, and other kidney function test is BUN, blood urea nitrogen. So you do estimation of GFR based on serum creatinine. Serum creatinine will give you some idea. There are some formulae that how much the renal function dysfunction is there. Okay, and we don't call it GFR. We call it eGFR, estimated GFR, because you are not directly measuring the GFR. That is invasive procedure. Invasive procedure. You are indirectly estimating the GFR based on the serum creatinine. So we don't call it GFR, we call it eGFR, estimated GFR. Okay, the unit of eGFR is milliliter per minute per 1.73 meter square, which is the normal human body surface area. Okay, now there are certain formulae. Cockcroft-Gault equation, no need to memorize. I'm not going to just to you have these formulae are already fed into the hospital computers. You put serum creatinine, and then it will calculate this dose is required in this patient. In the background of the computer, these formulae are fed. Okay. So stages. Yes. In the females, there are full papers I can give you where It's so complicated, full papers, where how did they dry? Because in case of females, in case the less dose is required, because in females, when you say the full body weight, compared to males, the females say less muscles, more fats. In their case, they require less amount of. This is a factor which they have calculated. Because if you calculate for both males and females the same, it may be misleading. Clear? Okay. So this is, already estimated in normal 90 to 120 estimated GFR, and then mild CKD, and intermediate, moderate, severe. So this is okay. Now approaches. Once you have determined based on the serum creatinine is previously is a CKD, mild, moderate, severe. Now the next thing is to calculate the appropriate dose in this patient. And what is the approach? The approach is either decrease the dose of the drug or decrease the frequency of dosing, or both. Basically, two approaches: decrease the dose, and I will show you how decreasing the dose or decreasing the frequency will affect the curve of the drug, plasma concentration of the drug in the body in various situations. Let's revisit some general pharmacology. Do you remember two types of doses? Loading and maintenance. Good. Loading is the higher dose, the first dose. The first higher dose, the loading dose is given to particular types of drugs. Which drugs? Do you remember? Not, not all drugs require a loading dose. Few drugs with some special pharmacokinetic property. Higher half-life, longer half-life. Remember, CSS is achieved after how many half-lives? 5 half-lives, 5 to 6. Suppose the half-life of the drug is 20 hours. Would you wait for 100 hours for the drug to become steady? So in that case, you can't wait for 4 days, 5 days for the drug to become at a steady state. In that case, your best bet would be to bring the plasma concentration of the drug rapidly, immediately into the therapeutic range. Otherwise, the graph which I showed you, in order to achieve that therapeutic range, the drug requires a long time. And if the half-life happens to be long, in that case, you have to wait a lot of time. And the patient requires a therapeutic effect now. The approach is give the high dose, loading dose, okay? Now, you see, if you go like this, Philo, it may take several days to achieve a thorough. Now, this is the range we require to achieve a beneficial response in a patient. In order to achieve this range, if you go with a routine dose like maintenance dose, it will take a lot of time. In situations where the effect is rapidly required, they'll go for the higher dose. Because in the background, what is the purpose? Why the half-life of the drug is longer? Yes? Volume of distribution is higher, and the drug, that means if the volume of distribution is higher, that means somewhere the drug is stored, sequestered. As soon as you injected the drug left the vascular compartment, it is no more in the blood, it went somewhere else and stored there. So the plasma concentration becomes extremely low. The plasma concentration becomes, do you remember the formula of VD? Volume of distribution? volume of distribution is equal to dose given upon concentration. So second year, POD problem. Forget it. Okay, no problem. General principle is higher the volume of distribution, the interpretation of higher volume of distribution means the drug has left the vascular compartment and is sequestered, stored maybe intracellular sites, maybe protein binding, maybe extracellular interstitial spaces. The drug is no more available to produce a pharmacological effect in the plasma. It is not there. So the dynamics of the drug will be the plasma concentration is low, it will be slowly released, dissociated from the binding sites and will come into the plasma for a extended period of time. That means the half-life will increase because the volume of distribution was higher. Did you get? This is background. If the volume of distribution is high, half-life is high, means the drug is sequestered. Now you give this amount of higher dose, 4 times, 6 times, so that all those saturating, binding sites, plasma proteins, interstitials, they are completely saturated now. You get higher concentration right away. Right away you get higher concentration. Are you with me? Okay, so this is the purpose of loading dose. Now the funny thing is, the formula of loading dose, if you remember, the same slides which we covered in POD. The loading dose is calculated. It is the target plasma concentration multiplied by volume of distribution. In the previous slides, I mentioned you have to either decrease the dose of the drug in renal dysfunction. Now I am rephrasing my statement. How? Now look at this formula of loading dose. Two things are required, two data sets are required. One is how much concentration do you require in the plasma? How much concentration do you require in the plasma, which is this one. Okay? This is a requirement in order to produce a therapeutic effect multiplied by volume of distribution. Okay? In that case, from these two parameters, which are required to calculate a loading dose, will there be any significant effect in case of renal dysfunction? Which one? That is a constant. Your requirement for plasma concentration will not change in case of renal dysfunction. For example, in order to produce an antibiotic effect of a drug, if the plasma concentration is 5 microgram per microliter, it will remain the same. It will remain the same. Will it change? So it is not changing in renal dysfunction. Volume of distribution may slightly change in case of expansion of extravascular compartment, but insignificant. So in that case, the food for thought for you is that whatever the renal dysfunction is, loading dose will not change. Did you get my point? Loading dose will not change because loading dose is dependent upon desired plasma concentration, which is constant. Volume of distribution is not very much constant, but not significantly change in renal dysfunction. So loading dose will remain the same, no change. It is the maintenance dose. I'll show you. Okay. Now look at the maintenance dose. Maintenance dose is mainly dependent upon how much the drug has been eliminated from the body. And the objective of maintenance dose is just to replenish that amount which has been excreted, isn't it? To give that amount or that dose of the drug which has been eliminated, give 20 milligram has been excreted, give 20 milligram. So it is dependent upon which parameter? Clearance or excretion. Now the formula for maintenance dose is same. steady state required plasma concentration multiplied by not volume of distribution multiplied by clearance. Now this is important thing which is affected in renal failure or dysfunction. In that case, it is the maintenance dose which has been to be modified, adjusted in case of renal dysfunction, not the loading dose. Clear? So I have mentioned CPSS means average steady state plasma concentration. Average steady state plasma concentration. What next? Once you have mentioned the degree of renal dysfunction, you have decided that in this case, either we have to decrease the dose or decrease the frequency. Now you have determined, let's see what is happening. Can you read please for me? Can you read? Yes, read, yes.
6-year-old middle people, 5 people thought pregnancy was for UTI 1 week ago based on urine analysis. However, this condition became worse over the last 2 days. Some stain of urine specimen showed gram-negative blood. A provisional diagnosis of urosepsis was made. The lab reports are
Now lab reports, HB 10,
but also testing on urea
15 down.
treatment.
So mild anemia, infection, and kidney function is poor, compromised. Okay? Now based on this, in order just to generate a discussion, this is a hypothetical situation. What are the drugs effective against gram-negative rods? Aminoglycosides are third, fourth, fifth generation cephalosporins. Most commonly used. There are others also, but just to generate the discussion and to convey the concepts. It turns out that the patient is hypersensitive to beta-lactam antibiotics. Means cephalosporins are out, aminoglycosides. Now, this is the patient, renal failure, urosepsis, gram-negative rods. You have no other option, just for the sake of discussion, to use aminoglycosides. Okay? Now, this is a story. In the background, this is a story. Let's build what is going to happen. For the routine drugs, normal drugs, if the half-life is hypothetical, half-life is 3 hours, you give 10 milligram, elimination, second dose, elimination, third dose, elimination. So the drug stays within the therapeutic range. Perfect. Fine. Normal patient, poor, proper renal function, half-life 3 hours. Now in renal dysfunction, the same patient, renal failure, the half-life has become now 6 hours, double. Now red curve indicates the comparison of renal failure patients is normal patients. Same dose, half of the drug more remained after first half-life, second half-life. Second dose, elimination. Third dose, because elimination, as I mentioned, because half-life has increased, the curve has changed now. No. Now you can see even after second dose, the drug has gone into toxic range. Unacceptable. What did I mention? Either decrease the dose or decrease the frequency. Let's see what happens. Half dose, same interval. Instead of 10, let's start with 5. Interval remains same. Good. Perfect. Happy? The drug is within the range by decreasing the dose to half, 50%. The other strategy is decreasing the frequency. Same dose, frequency, decrease the frequency. Instead of twice daily, you give once daily. Let's see, double interval. So we skip the dose here. We skip the dose here, gave full dose, but skip the dose here. Huh? What happened? Yes, same. Okay. So second dose, we skip the dose here once again. Are you happy? Almost similar pattern. Good. So for most of the drugs, this strategy of decreasing the dose or decreasing the frequency both work well. No problem. But now recall our patient who requires aminoglycosides. Now, situation is different in that situation. I want to show you multiple situations, how the strategies, multiple strategies work in different situations. In case of aminoglycosides, normal renal function, drug, elimination, second dose, elimination, second dose. Now, note two things, two important pharmacokinetic parameters here, which are different from other drugs here. One is bactericidal peak. Are you seeing this peak is going beyond the range that is required in case of aminoglycoside? For some time, maybe half an hour or 1 hour, did I teach you or someone who, I don't remember who taught you aminoglycoside in POD about the post-antibiotic effect? Hmm? Did I teach you? So what is what is the philosophy underlying post-antibiotic effect?
But even those who went down, there's still effect.
Effect. So this is because of the post-antibiotic effect. This is because of the bactericidal peak. You achieve high concentration for a brief period of time, even for 30 minutes or so. The drug accumulates in the cells. It attaches there, and then there is elimination later on. But the post-antibiotic effect continues. Even the drug is not there. Actually, at least you cannot measure in plasma. Now, one thing is bactericidal peak has to be achieved in order to exert maximum kill of the bacteria, efficacy. The other is safety profile. The other is safety profile. Like bactericidal peak, the drug must attain a safe trough level. Safe trough level below the range, therapeutic range, even for some time, 30 minutes, 40 minutes, 1 hour, to reduce the chances of nephrotoxicity. This is for the efficacy. Aminoglycoside must attain bactericidal peak. This is for the safety. The aminoglycoside must attain a safer trough. If these are not there, if the drug does not achieve, it is less effective. If it does not achieve safer trough, the drug becomes highly toxic. So just keep in mind. Now, application, yes, only for aminoglycoside, yes. That is why I am telling you that generally that previous strategy works. But for aminoglycosides, just to tell you that strategies may be different in different situations. Okay. Now, in a patient with renal dysfunction, now half-life has increased, the curve has changed. Normal patient, red, patient with poor renal function. Administration, elimination. Although the drug has bactericidal peak, very good peak, but it does not attain the safe trough or non-toxic trough. So in this situation, dangerous. Your strategy is half dose, just like we did in the previous situation. Are you happy? Both things are not working. There is no bactericidal peak and there is no non-toxic trough, safe trough. So that means In the ordinary drugs, majority of the drugs, this strategy of decreasing the dose was working, we saw in the previous graph, but in case of aminoglycosides, this is not working. So there is no point in decreasing the dose. There is no efficacy and increased toxicity. This approach is useless. Okay, let's do other thing. Don't change the dose. Increase the interval. See, it works well. So for aminoglycosides, we started with the same dose. Just skip the dose. Full dose. Skip the dose. Bactericidal peak. Good. Non-toxic trough or safe trough is achieved. So in case of aminoglycoside, this is exception. You don't decrease the dose, rather decrease the frequency of doses. Clear? So these are the common drugs you don't require to memorize, just for your information. Where the drugs dose adjustment is required. And for these drugs, dose adjustment is not required because they are not excreted through kidneys. Now the last few slides about, in some situations, you would want to enhance the excretion of the drugs from the kidneys quickly. Can you do this? Can you do this? Can you manipulate the excretion of the drugs? How? Okay, very good. So the drugs are mostly either the metabolites of the drugs are either, or even the parent drug are either acidic or basic. Now the basic principle of renal physiology is everything which is in the plasma, except the bigger molecules like cells, plasma proteins, and other things, everything is filtered through glomerular filtration, and then the process of reabsorption starts, starting from proximal tubule, loop of Henle, distal tubules, collecting ducts, everything, fine-tuning of the glucose, sodium, and other things Manal must have mentioned yesterday. So almost 99% of the sodium, for example, is reabsorbed. 100% of the glucose is reabsorbed. Okay, various transporters are operating in the tubular fluid from the luminal side. Now, the question is, in case of basic drugs, if you have the means, tools to make the urine acidic, what will happen? Those basic drugs will be highly ionized in that acidic urine. Am I right? Okay. So once those drugs or metabolites are filtered and they are in the proximal tubule, now from that process on, reabsorption of the solutes starts. Now the degree of ionization of the solute has a greater impact on the reabsorption process. More the degree of ionization, more the molecules are in the ionized state, less will be the reabsorption. Am I right? Oh, come on. Hello, what are you showing? Okay, offer. Okay. More the degree of ionization of solute in the tubular fluid, in the proximal tubule or loop of Henle, what will be the outcome on the reabsorption process? Will be less or more? Obviously, it will be less. Ionized molecules are difficult to be passively diffused, obviously. So if you are making the urine more acidic, basic drugs, parent molecules or metabolites will be difficult to be reabsorbed. Conversely, reabsorbed. If you make the urine more basic, alkaline, the acidic drugs will be difficult to be absorbed in both situations. Now you need to know the character of the drug. In toxicity situation, in poisoning, someone has taken accidentally or intentionally has taken the high dose, the chances of toxicity. Now, first thing is you have to remove the drug from the body. If the patient has taken the drug right away, 15 minutes before, 15 minutes before, then your choice would be the drug should not go into the systemic circulation before it has been absorbed. Induce the vomiting. Induce the vomiting, and then the unabsorbed drug has to be removed from the GIT. Other thing is the drug has left the GIT and is in the systemic circulation. So now you have to accelerate the excretion of the drug. Know the character of the drug, whether it is acidic or basic. Accordingly, you can change the character of the acidic. Okay. Degree of ionization has effect. Okay. These principles of excretion can be manipulated when elimination of certain drugs needs to be accelerated in situations of toxicity or poisoning. Now, we have certain drugs which are very safe urine alkalinizer, like sodium bicarbonate, potassium or sodium citrate, or in rare situations we do not use. Manal must have mentioned one of the important side effects of acetazolamide carbonic anhydrase inhibitor is metabolic acidosis because of the urinary alkalosis. Because a lot of bicarbonates are excreted, isn't it? So urine becomes highly alkaline, leading to metabolic acidosis. So if the urine becomes highly alkaline, more acidic drugs will be excreted. So administered sodium bicarb, potassium or sodium citrate, or acetazolamide, you can enhance the elimination of weak acids like salicylate. Conversely, on the other side of the spectrum, make the urine acidic, like administration of high dose of ascorbic acid, vitamin C. Urine becomes acidic, and more basic drugs will be readily excreted in that medium. Now I will show you the graph, which I took from some papers. Now see, salicylate, aspirin, acidic, neutral pH. This is the pH of normal pH, 5.5. Urine is slightly acidic, isn't it? So under those physiological circumstances, salicylate is not excreted or very slowly excreted, very slowly. In salicylate poisoning, aspirin toxicity makes the urine alkaline with sodium bicarbonate, increase the pH, drastic effect, dramatic effect on the excretion of salicylate. By increasing the or decreasing the pH, making the urine more alkaline, so more excretion of salicylate. Other side, this one, amphetamine, a prototype poisoning. Amphetamine is a basic, makes the urine acidic. As soon as you make the urine acidic, more acidic, jump of excretion of methamphetamine, a basic drug, clearly shows you that changing the pH of the urine has a drastic effect on the excretion of certain drugs and their metabolites. Clear? Yes, it is when you encounter a patient with amphetamine poisoning, toxicity, overdose, you can acidify the urine with ascorbic acid and drug will be eliminated rapidly. Is it there? Okay, that's it for today. Thank you.